Actually, my talk was put as a filler. So in case we are supposed to stop at 6:30, but Arun is keeping on pushing me. There are some reasons. So when I was actually contacting everybody on phone for for talks, so actually Joshi was asking, Ramesh, should we have all this serious CME in the midst of the reunion?
I also asked.
Yeah, you also asked. Why you have this serious CME? So actually we should be discussing more lighter things. So I think last 2.5 hours you are discussing real solid things. So we'll go to something lighter. I may make some provocative statements. Don't throw me out of this place.
Reciprocation will come from here.
I'm going to make some provocative statements. This will be very short talk. Please stop me at the time. So all of us have been talking about evidence-based medicine. Do we follow it actually always? What is exactly evidence? Do we use it selectively as based on our convenience or somebody else's convenience? Are we really doing evidence-based medicine? Can I use the, just play that? This cursor is... Arun, what is that? Can you tell me what is that?
No.
How do you know? What is evidence? Have you seen it? Have you seen it?
No, sir.
Now, how do you know it's a dog park? Go to the next slide. Next slide. So we have a 28-year-old male, unmarried male. The father died from FAP with colorectal carcinoma 25 years back. Even after that bad experience, he had just one surveillance screening scopy. He was found to have some scarce polyps and he was advised close follow-up, but he never turned up as the usual Malayali. His father's sister had IPA for FAP 23 years back. And then 15 years later, she also had a Whipple for a dural carcinoma. And then she was disease-free. In spite of this young fellow was never on follow-up. He was not on on surveillance. Then he came with bleeding PR on digital examination. He has a large ulcer-proliferative growth, restricted mobility, 2 biopsies, 1 under anesthesia, proper EUA, good chunk taken, high-grade dysplasia. Colonoscopy, hundreds of polyps, adenomatous polyps. CA is slightly high, MRI, T3N1. Metastatic workup negative. So now what do we do? Well, I'm just asking everybody. What do we do? We know the standard of care is NSCRT if it is a carcinoma. So I'm asking, everybody wants biopsy, correct? So you want, I hope Krishna Madam has not come yet. Pathologists are there. So what do you mean by evidence? So evidence, people say that if the pathologist says it's a carcinoma, you are willing to take it as an evidence. What if the surgeon says it's a carcinoma, you are not willing to take it as an evidence? So what do you mean by evidence? The pathologist is seeing something, the surgeon is seeing, feeling, smelling, but still you are not hearing, you are not willing to take it as an evidence. Radiologist is seeing, that you are willing to take it as evidence. So what do you mean by evidence? That is my question. So there is no evidence of malignancy. The educated finger of a surgeon, all of us sitting here, you know that. For example, I just quoting. So these fingers are so sensitive. He knows what is what, where is how tight is a suture. So there is something more than evidence. So what do you mean by evidence? It's not very clear. This is just to ponder and argue. And so is what said by the pathologist evidence? Is it what is given to the radiologist evidence? Huh? Do you have a point there? I have a point, obvious. I know surgeons smelling and diagnosing. Kurula sir, P. Thomas sir. I have heard of surgeons hearing history and giving a diagnosis. Lal sir, even P. Thomas sir. Madhu doesn't seem to agree. You go to the deceased donor a live transplant, this is not a living transplant program, Dr. Sudhi would agree. In the most of Europe, especially in UK, the surgeon chooses the liver based on the naked eye appearance. So is that evidence of an experienced surgeon? The naked eye experience of a surgeon is the criteria to choose the liver. I see it when I went to Cambridge for fellowship, 1.5 months. 2 cases actually were rejected by the chief surgeon because the liver looked fatty. So selectively we are appearing using this term of evidence. So actually, is patient's history evidence? Can you believe a patient? You're willing to believe the patient, but you're not willing to believe yourself. Correct? So surgeons, you're presuming that all of us are biased by default. So you need to think about it. So actually, when do you need actually real evidence? When a drug or an intervention is really going to change, when you have an expensive drug or a very inexpensive drug which is going to make a lot of difference. In such a situation, it can produce drastic changes in outcomes. For example, there are studies which shows that aspirin, actually Amrita had done a study which shows aspirin can reduce the rejection rates. Although there are some criticisms about that study. So those sort of things, yes. Or you have prostaglandin, is it effective? Does it have an outcome? Does it affect the outcomes of transplant? Prostacyclin. It is shown to be not effective. Expensive drugs, does it change the course of an illness? There it is good. But not for a young fellow with an obviously advanced malignancy. You are saying you are going to wait for evidence. I don't agree with that. So we need to ponder about that a lot. I'm not against evidence-based medicine, mind you. We are doing a randomized controlled trial right now on pancreatic surgery. So where it matters, evidence-based. Huh? Again, EHPVO, somebody said, don't prescribe beta blockers. There is no evidence. There's no evidence to give it. What is the harm in giving beta blockers? Beta blockers, we know that it will reduce the cardiac output, it will reduce portal hypertension. Why do you want to wait for evidence for that? You are giving ecosprin, Populate for every other person. I personally know of at least 4 or 5 family friends, including a cardiologist, who developed subdural hematoma because of antiplatelets and was in hospital for months together. Is there that solid evidence for using antiplatelets for 70-year-old, 80-year-old, 80+ people? So definitely beta blockers are not deadlier than antiplatelets. So there was some heated argument in a portal hypertension discussion. There's no evidence for giving beta blockers in EHPV. It's not going to kill that patient. So all the senses, you need to use all your senses for good clinical practice. That is why not just evidence given by certain specialties. So, and actually, is it feasible to get evidence for all things we practice? Do you really have evidence for everything? For NET, for example, for rare diseases, it's not possible to get level 1 evidence. So should lack of evidence, I don't think, should be an excuse to deny treatment. Thank you.